one of the things that I'm focusing on, and you've heard already about the many achievements we've had in multiple myeloma, is can we truly cure myeloma by early detection and early prevention? So I'll try to take you through the next 20 minutes to convince you through that and see if we can work, all of us, together on this. It's not working, yeah. I can use this. Yes, perfect. So many of you know very well that myeloma is preceded by the precursor conditions MGUS and smoldering myeloma. And at least in the US, if you think about the incidence of multiple myeloma or the incidence of MGUS in the population, in the general population, it's 3% over the age of 50, and it increases with age. And yet we know that African Americans and first-degree relatives of patients with myeloma have a 3 times more common incidence to develop MGUS. With all of that, and with many of us knowing people who are walking around with MGUS and not being diagnosed, it's a big problem because we could potentially, if we can find a cure, have an early detection and early prevention for many of those patients. Now, Vince Rajkumar showed you beautifully today about MGUS and smoldering myeloma and the diagnosis of smoldering disease. What we know is that in patients with smoldering disease, they have an incidence or a disease progression of 10% per year. And we know very well that almost every single patient who is diagnosed today with multiple myeloma must have had an MGUS or a smoldering myeloma before they were diagnosed with this. Yet we don't look for it, we do not screen for it, and that's why we don't find it. And patients come in when they have bone disease or anemia or renal failure, and that's when we find them. So our vision or our hope was that we do something different. We look at patients with breast cancer or many other cancers, and when a patient goes in at age 40 or 45, you go in for early detection, you go for mammograms and screening for many cancers, colonoscopies, PSA, and mammography. Yet we do not even do a blood test to look for multiple myeloma, which is a very simple test that we can do for blood cancers. And when we even diagnose it early, and a woman who has early breast cancer or DCIS, we never tell her, you know what, you have an early breast cancer. Why don't you wait until you have lytic lesions everywhere and fractures and metastatic disease, and then I'll treat you. Yet for multiple myeloma, we see every day patients with smoldering disease who have a high chance of progressing in the next couple of years, and we tell them, go ahead, wait until you have lytic lesions, anemia, renal failure, and then I'll treat you. And that concept of treating late, treating when we have metastatic myeloma, is maybe the problem that we haven't cured the disease yet. So potentially early treatment can make a difference, even with the drugs that we have so far, can potentially cure our patients with myeloma. So this is our hope. Our hope is that in the next few years, we will screen patients with myeloma, look for MGUS and smoldering disease, and have a program of early intervention and early detection, and potentially cure myeloma by early therapeutic intervention in those patients. Now, how do we do that? We know that many patients are diagnosed with MGUS and smoldering myeloma but will not need treatment because they will likely not progress in their lifetime. And you don't want to treat every single patient. So you want to truly understand mechanisms of disease progression in a lifetime of a patient. And that we divided it in different parts. We divided it by the genomic alterations, genetics and epigenetics that occur in the tumor clone itself and clonal heterogeneity in those patients and clonal progression. We also divided it by looking at the tumor microenvironment. Bart Barloghi talked about it today in the earlier sessions. Where is the role of the microenvironment? So we started looking at the immune and the non-immune parts of the tumor microenvironment and how that regulates disease progression so that we can have true biomarkers of progression in our patients. We can see a patient who's 40 years old who has the same M spike and the same bone marrow involvement as another one. And for one of them, we'll say, you have a high risk of progressing to myeloma. And another, we will say, you don't need treatment. You can watch and wait for now. The other thing that we talked about is we could potentially then develop personalized or precision medicine for those patients. Instead of just hitting them with everything that we have, we would potentially develop specific therapy for those patients and have true precision medicine in the future. So I'll take you through a little bit of this. The first part is the mechanisms of disease progression and clonal evolution from MGUS to myeloma. For many years now, we've had a better understanding of how myeloma develops and how many primary genetic events as well as secondary events occur in those patients. Yet most of those studies were done in patients who have overt disease, who have overt myeloma. What we don't know yet is what are those early events that lead to progression and whether there is true secondary acquisition of mutations that lead to progression in the lifetime of a a patient. So we know the primary and secondary genetic events, yet we don't know which one comes after which. And would you acquire a P53 mutation early on? Would that lead to progression? Or do you need other things that will lead to progression in this patient? We haven't even looked at the epigenetic regulation of disease progression in those patients. So we're now going backwards and looking at all of those patients and trying to understand mechanisms of clonal evolution and what truly leads to disease progression in our patients. And we've tried to do that through collaborations with many of you, including the UK group, Mayo Clinic, and many others, where we look at samples of patients who have progressed or did not progress, and look at bone marrow biopsies, but also look at liquid biopsies or blood biopsies, and try to understand the mutational landscape as well as the mechanisms of clonal evolution in those patients. And here's one of the examples where we had it in smoldering myeloma, and we're working now on the MGUS samples, where we've screened over 200 samples of smoldering disease. This is just data from 100 or so of those patients. And we found that there is indeed the same SNVs and the same copy number alterations you see in myeloma. But interestingly, half of the patients were very silent. The genome was silent, and there were no copy number alterations or mutations that were detected. And in fact, if you go back and look at the samples that progressed, the patients who had in 5 years progressed to overt myeloma and those who did not progress to overt myeloma, we find interestingly that those who progressed, their smoldering sample indeed had some mutations and copy number alterations early on. And when you try to define which ones truly lead to progression, we found that indeed the MAP kinase pathway, so KRAS and RAS and BRAF, as well as MYC alterations, which would be amplifications and translocation, would actually correlate significantly with disease progression in those patients. So now, hopefully, instead of just saying to a patient that you have an M spike that's 3 grams or a light chain ratio that's elevated, you can also add genomic and clinical alterations together to give a patient a better prognostic model so that we can say, indeed, you will progress to overt myeloma or not. The other part that we've been doing, and this is work by Salomon Mani, Thierry Facon just talked about him as an amazing postdoc in my lab, has shown that indeed we can use liquid biopsies or blood biopsies as a good surrogate for bone marrow biopsies. And here what we did, and this paper just came out last week in Nature Communication, where we compared bone marrow biopsy samples to liquid biopsies. So we did both the circulating tumor cells as well as the circulating free DNA from the same patients, and asked the questions, can you detect the same mutations and the same copy number alterations that you have in a bone marrow biopsy in a liquid biopsy for that patient? And what we did is we collaborated with the Broad Institute to screen many of those samples, hundreds and hundreds of samples, early on to try and see, can you detect early on tumor DNA in the peripheral blood of those patients? So we used a method called ultra-low pass whole genome sequencing, and this is a very easy sequencing at 0.1x, so it's a very low level of sequencing where you can detect if there is enough tumor DNA or not. And you can see here that you can detect copy number alterations even at 0.1x level that looks exactly the same as you've had a deeper level of whole exome or whole genome sequencing. And that costs you only $20. So you can screen thousands of samples with an ultra-low pass and then later on decide whether you will do whole exome sequencing, deeper whole genome sequencing, or deeper targeted sequencing, which is what we are doing right now at 3000x. So this is the methods at the Broad Institute. All of it is automated. I think they have 3 employees and 500 machines. So it makes a huge difference of really, you can screen thousands of samples in no time. And what we've done, and you can see here that we've looked at patients with MGUS, smoldering myeloma, overt disease, and relapse disease, is just looking at the ultra-low pass whole genome sequencing, you can actually detect that indeed those who have a higher tumor burden will have a higher tumor fraction, and it correlates significantly with disease progression with the ISS staging system. And the same occurred with the circulating tumor cells. So whether you have CTCs or cfDNA, you have exactly the same correlation with disease progression. Now, not only you can do that, but you can also look at the response in those patients. Those who are responding or those who are progressing, their cfDNA tumor fraction will increase or decrease in the same manner. So potentially this could be used in prospective clinical trials when we do monthly samples on our patients, and instead of just looking at the M spike, you can look at the ultra-low pass whole genome sequencing of those samples and then go deeper and look at if it was a new mutation or a new alteration that occurred in that patient in response to therapy. The other thing we did is we did take a bone marrow sample, a cfDNA sample, and a CTC sample from the same patient at the same time point and did whole exome sequencing. And I'm showing you 4 examples here. And interestingly, we found that the clonal mutations, which are in blue, are identical in all 3 compartments, meaning you do not potentially need a bone marrow biopsy. You can see every single clonal mutation in the peripheral blood of that same patient at the same time point you had it when you had the bone marrow biopsy. Not only that, but the subclonal mutations were actually, some of them were more present in the peripheral blood. As you can see in the last example, we could see a TP53 mutation in a patient in their peripheral blood, but not in the bone marrow biopsy. And that's important because we take a bone marrow biopsy from one area, one focal area, yet the marrow is full of multiple focal areas. And again, this could be used potentially better as a blood biopsy to give us a better understanding of the whole marrow or the whole disease in those patients, rather than a one single area. So in the next part I'll take you through is the bone marrow microenvironment, and try to just give you a couple of examples of what we're trying to do to understand better the mechanisms of how the immune cells or the tumor microenvironment truly work as a marker of disease progression, but also that they're not just bystander, that there's an active role of the immune cells in allowing disease progression. And I like to show this. This is the same seed in different microenvironments or in different macroenvironments. And this is, again, the seed and soil hypothesis of Dr. Paget, where indeed you can see that the same MGUS cells, the same cells that had the early mutations, could potentially, in a very different environment, a permissive microenvironment or a non-permissive one, either go on to progress to myeloma, or the same cells could never progress to myeloma. So how can we understand this? What we're doing right now is we're trying to take it apart through understanding at the single cell level the role of the immune cells and the non-immune cells. And we're doing that through single cell RNA sequencing, whether it's through DROP-seq, as you can see here, or 10x genomics. And here I'm just showing you an example of a few samples where we look at the tumor cells, but also at the non-tumor cells, which is more important for us to understand better what is the role of T cells, NK cells, B cells, and monocytes and macrophages in disease progression. And we're serially taking samples of those who progressed and those who did not progress to try and understand not only the number of T cells or NK cells or macrophages, but also which genes are dysregulated in those samples that lead potentially to a permissive microenvironment in them. And we're trying to take that into in vivo modeling. You cannot just understand it by trying to take patient samples, but we're also looking at in vivo models of disease progression through the bone marrow niche. And this is one of those where we've taken myeloma cell lines, put different fluorophores so that you can have subclonality. And you can see here we have different 15 subclones. We call this the rainbow cell line. Put it into mice into one area. We call it the plasmacytoma site, and wait for dissemination or metastasis to happen. And you can see that in vitro, you would have no problems. All the subclones, all the 15 subclones will grow together without any problems, and they co-compete with each other. Yet in vivo, when you look at the primary site, which is the first part, or the primary tumor, they're all competing. And when you go to the metastasis or disseminated site, there is one subclone that takes over and becomes the winner clone. And that's probably what happens in our patients, where there is a winner clone that takes over and leads to clonal progression in the presence of the bone marrow niche, in the presence of that inhibition or potentially permissive environment of the bone marrow niche. And this is just showing it to you by confocal microscopy. The implantation site has multiple areas or multiple clones growing together, and they co-compete with each other. Yet when you go to the metastatic side, there is almost replacement of all the different subclones with only one that takes it over. And I'm not going to show it in details, but we've done RNA sequencing as well as whole exome sequencing on those samples to try and understand which genes or which molecules are important for this dysregulation. And then we've done CRISPR knockout to try and understand functionally why some genes are important for dissemination or not. The last part that I'll show you in the immune microenvironment is the role of Tregs in disease progression. And this was just published a couple of weeks ago in JCI, where we showed that during disease progression in the VK-MYC mouse model, we found that indeed the Tregs are actually upregulated in the bone marrow microenvironment of the mice with VK-MYC compared to control. And this was shown by CyTOF, as you can see here, but also by RNA sequencing. And we asked the question, which part of the Treg is important? And we actually found a very important part of interferon alpha being regulated there. But we also asked whether if you can deplete Tregs completely from those mice, can you prevent progression? Can you just prevent myeloma progression by changing the immune microenvironment to make it non-permissive? And indeed, by using diphtheria toxin, so conditional knockout of Tregs with diphtheria toxin or the Dreg mice, you find indeed that you completely abrogate myeloma from progressing, and you find complete normal survival of those mice and no M spike in those mice that had the Dreg or the Tregs completely depleted. So again, maybe manipulating the immune system early on in early stages of MGUS or smoldering can potentially completely cure our patients with myeloma. So in the last part, I'll tell you how we translate that into the clinic. Over a couple of years ago, we started a Center for Prevention of Progression at Dana-Farber with the whole purpose is that we will try and prevent early blood cancers. And that includes MDS or CHIP mutations, the clonal hematopoiesis, early CLL, as well as, of course, early myeloma. And we're doing that through early lab work, but also through seeing patients and doing interventions and clinical trials. And the first thing we notice is that it's very hard to just bring samples to Dana-Farber and not have other thousands and thousands of patients who have MGUS and smoldering everywhere else, nationwide and internationally, to be part of this whole effort. So we started the Peak Crowd trial, which is an online crowdsourcing trial. We're crowdsourcing for patients instead of crowdsourcing for money. And we truly empower patients to really give us their samples. So this is an online source for patients. They go online, consent. They do not need a physician intermediate between them and the research. And then they complete the survey, and we can send them a kit wherever they live, and they will get the blood or bone marrow samples sent back to us. And we've been successful to get 1,500 samples or 1,500 patients with over 3,000 samples sent to us within the last couple of years. Now, you know very well that therapeutic interventions are the end goal for this so that we can make a difference in treatment in those patients. And Mariví Matios has been the first one to show, indeed, that you can prevent progression by early therapeutic interventions with Revlimid and dexamethasone. And this has been followed by many clinical trials in many centers. These are just some of those, including the vaccine trials with Ken, Nikhil, and Paul, but also some clinical trials with immunological therapies, with antibodies, with daratumumab, and we're hoping to have many more in the future. And the last one that I'll show you, which is a new study that's actually a screening study that we just got awarded for the Stand Up to Cancer grant. And we have $10 million to do the first screening study in the US for patients with MGUS and smoldering myeloma. And the whole idea is we will screen high-risk population, African Americans, as well as first-degree relatives over the age of 45. It will be all online. We'll screen 50,000 individuals. And those who have MGUS and smoldering myeloma, we will ask questions of genomic evolution and tumor microenvironment. And those who are negative, we will rescreen them again in 3 years. And these are the aims, including genomic characteristics, race and obesity, germline characteristics, looking at microenvironmental factors, but also trying to develop imaging and therapeutic modalities. And we would love to work with everyone here in this room to truly make this a change in our way of screening our patients and looking at our patients and potentially curing our myeloma patients early. This is really effort from many people. This is including the School of Public Health at the Harvard School of Public Health, the Mayo Clinic, Johns Hopkins, many others, and including other foundations too, and not just Stand Up to Cancer. So I'll end with telling you that I would like to thank the committee for giving me the award, but when I think about what I've done, it hasn't been really my effort alone, but truly a team effort and a great effort from many people, and it takes a village to make anything happen. I'll just tell you that I'm actually originally from Egypt, but I lived in Nigeria. I was born in Nigeria and lived there for 13 years, and then I came to the US 20 years ago, and I owe a lot to many mentors and many people in the US who made my life come true and actually get the American dream come true for me. I also want to thank many people who are my family, of course, my parents, my sisters, my daughter here, and recently my dog. My mentors who are the most important, Bob Kyle. I know he's not here, but he has truly been my mentor and my supporter. And it's an honor for me to go back to work on MGUS after many years because it really completes the circle for me being trained at Mayo Clinic with Bob Kyle, Maury and Raphael, Ken, he's here. Thank you, Ken. And of course, Rob Soifer and David Rudman and many others who have really made a difference in my life. My friends and work family, I can tell you that these are the people who make every day happen, and they actually make everything truly successful, and I just take the credit sometimes. You can see Salomon and Xavier here, so we've got the French connection here. And some of you know my motto, but it's the fierce urgency of now. And I really feel that every day counts for us to make a difference for our patients. It's truly an honor to work in myeloma because we've changed our treatment in the last 10, 15 years. I still remember as a fellow, we were starting with Vince Rajkumar, the first trials of Stel-Dex, and we were very excited to have novel therapy in myeloma. And now we're lucky to have so many drugs and so many combinations, and we're talking about cure. Yet there is a lot more to be done in myeloma. And I hope we truly make a difference for our patients. So with that, I'd like to thank you all and thank, of course, my collaborators, my colleagues, lab members, clinical team members, our funders, the NIH, Stand Up to Cancer, MMRF, Leukemia Lymphoma Society, IMF, and of course, our patients. Thank you.